All right. Come on in, everyone. Come on in. It's time. Faites vos jeux, mesdames et messieurs. Faites vos jeux. Well, you're the beginning and the beginning. All right. So, our next speaker, Dr. Herbert Silverstein, again, will talk to us about intratympanic dexamethasone with microwick. 1 month? Transtympanic?
Yeah.
Okay.
Yeah.
All right, Herb.
All right. So I like to give the end of the talk before the beginning of the talk so that you can sleep through the whole talk and you don't have to pay attention. But anyway, this started, we've been using the microwick to introduce medications into the middle ear, similar to the ophthalmologists. You know, they put drops in the eye and they just go in the eye. Well, this way, with a microwick, the patient can put the drops in their ear. They don't have to keep coming back to the office for injection. And we've been doing this for about 20 years. And patients with Meniere's disease kept telling me, saying, "Doctor, you know, the pressure in the ear is better and my tinnitus is better." And I kept hearing this over and over again. And finally I decided, well, maybe we should look at the patients and see exactly what's happening with their tinnitus, because I don't know any other drug that we have that will help tinnitus. And this seems like it may be a possibility. So we went and evaluated some of our cases. So what we did was we took patients and we divided them up into two groups. The group one were the patients that required no further procedure for Meniere's disease. In other words, they had the attacks of Meniere's disease and hearing loss, pressure and fullness in their ear, and we decided to put a microwick and treat them with dexamethasone for a month, and they needed no further treatment. Then there was a group that didn't work at all, so that was 15% of them that required further procedures like gentamicin or a nerve section or a labyrinthectomy. So this, the microwick, when we first invented it, we used we used a tube to put the microwick in, and you'll see that here. So we use a laser to make the opening in the eardrum, and then we put an endoscope in the ear. And we were using, like Dr. Smuha was talking about, the endoscopes. We wrote a book on endoscopic ear surgery, and actually I fell behind because I didn't go ahead with surgery using the endoscopes like some of the otologists are doing today. So that's the way things are going in the future. So I missed out on that, but used the endoscopes a lot for diagnostic procedures and for helping in surgery to make sure the cholesteatoma was out. So we put the tube in the posterior inferior quadrant over the round window, and the tube and the microwick goes in, and then that's the way it goes. Now, about 3 years ago, I decided to stop using the tube, and I just make an opening in the eardrum now and put the microwick in directly through the eardrum and put some gel foam in the middle ear. So this shows it without the tube. So we're putting some gel foam down into the round window niche, and then the microwick will be placed in over that. And the reason I used the tube originally was I was afraid we were going to get perforations from the steroids affecting the eardrum, affecting the healing of the eardrum. But this hasn't been the case, and the ears have been healing up pretty much just the way they did with the tube. So this is a lot. This takes about 10 minutes off the case, and you just make the hole, put the gel foam in, and the tube in. So it's a pretty quick procedure. So we took patients from 2017 to 2020. Before and after the micro-wick, we asked them to do a self-reported questionnaire and evaluate their tinnitus, pressure, dizziness, vertigo, and hearing loss. And no improvement, 10 being the resolution of the symptoms, 1 being no improvement, 10 being complete resolution of the symptoms. And the demographics were about equal in both groups. Both age groups are about the same, male and female, and the time since they had the Meniere's. So 17 patients, or 50%, reported a subjective improvement in tinnitus. And the average pre-treatment score was 6.57, and it went to 5.18. 20 patients, or 59%, reported subjective improvement in oral fullness. And the average treatment score was from 6.7 to 4.9. And 27 patients, or 79%, reported subjective improvement in the vertigo. The average pre-treatment score was 6.3 and went to 3.17. 7 patients reported a subjective improvement in hearing loss. It didn't seem to help the hearing as much as I thought it would be. The average treatment score was 5.7 and was 6.3 afterwards. And this is just a graph that shows you the improvement in the group 1 that didn't need further treatment, and showed that in the tinnitus, fullness, and vertigo, we had a nice improvement, but with hearing loss, there really wasn't that much. And in group 2, here you can see that there's no change after the treatment with dexamethasone for 1 month. Their speech reception thresholds were the same, and discrimination stayed about the same. So in the group 1, there was statistically significant improvement in tinnitus, oral fullness, and vertigo. And in the group 2, the t-test showed that there was not statistically significant change in the symptoms. Overall, 78% of the participants indicated they would recommend the transtympanic dexamethasone perfusion for the treatment of Meniere's disease. As far as complications, we had 1 case of external otitis and 1 perforation that needed fascia repair. So IT steroids, I believe, for 1 month using a micro-wick may be superior to the results of just IT injections. It's just my impression for treatment of patients for so many years that early treatment of high drops usually gives better results. And the pressure and fullness caused by the endolymphatic high drops responds to steroids in a high percentage of cases, and the earlier you treat them, the better. And tinnitus related to high drops can be improved for 1 month treatment in about 50%. So I think this is pretty interesting because I had no idea. I really never paid attention to the patients talking about their tinnitus. And until after I heard so many times, I said, well, we got to look at it and see. But I think this is one drug that will help patients with tinnitus if they have high drops. Now, we've tried using steroids for tinnitus from sensory neural hearing loss, and that definitely doesn't work as far as I can see. But I think with the Meniere's, it's worth a try. Thank you.
You were fast. We have time for a question, comment. Okay, next, Alan Young. Alan's going to talk about cochlear implants and cognitive decline. Alan returns to us from Vegas.
Yes. Yeah. Well, I'm Alan Young. I'm number 49. So, like Dr. Watson said, I'm currently in Vegas, and it's amazing to see 3 generations of people that Dr. Silverstein mentored and guided, from the baby boomers all the way to the millennials. And so, Dr. Silverstein, if if you're willing to work for another 5 years, you're going to get your first Gen Z fellows. All right. All right. So this is a paper, an update on a study that we've been doing for quite a few years at the Silverstein Institute, and quite a number of fellows from the millennial generation have worked on this for the last few years. So we've been really looking at how long-term cognition and speech recognition scores are affected after cochlear implantation in the elderly. So just as everyone know, hearing loss, especially those over 65, is quite common, and it costs billions and billions of dollars annually worldwide, leading to cognitive decline, social isolation, reduced quality of life, and other comorbidities. The prior paper that was published in 2019, we had shown that cochlear implants in adults significantly improve their auditory function, their speech recognition score, and their quality of life. And especially being in Sarasota, and even in the whole country, the demographics of age over 80 is now the fastest growing demographic, and also the fastest growing recipients of CIs. So in the past, CI has always been traditionally controversial in the elderly due to concerns of their cochlear fragility, their diminished neuroplasticity, age-related degeneration, and certain things that predict CI success include how long they've been deaf, how long they've been using hearing aids, any residual hearing loss, and then their current level of cognitive decline. But there are several studies in the literature that's shown that elderly patients achieve quite similar results to their younger counterparts by 12 months in their speech recognition scores. And the study in 2019 showed that preoperative cognition was actually a key predictor in postoperative speech recognition performance after a CI implant. There was the theory that regardless of their age, people who had poor cognition, as scored on this self-administered gerocognitive exams, the SAGE, had poor performance. Now, we've used the SAGE criteria study, but there are several other screenings, but all the other screenings usually require a lot of time, require a lot of personnel, a lot of special equipment, whereas the SAGE, it's a brief 22 question, it's self-administered, and it doesn't require much equipment, doesn't require much personnel, and it can be easily done, and it can measure a wide variety of functions like language, memory, executive functions, mathematical skills, visual spatial skills, and it only requires a 6th grade reading level. And it's 79% sensitive in detecting cognitive impairment, and quite statistically similar to the mini mental state examination. So the goal of this follow-up study is to really see how the preoperative cognition, as measured by the STAGE testing, can impact long-term speech recognition after CI in the elderly beyond 1 year, and if having a CI plays a role in improving their post-operative cognition levels. So it's a prospective study, and we included every patient 65 or older who underwent a CI from January 2016 to as recently as 2023. They all completed the SAGE pre-implantation, again at the 1-year anniversary post-implantation, and now for this new study at 2 years after implantation. There were 55 patients who met all the inclusion criteria with all the data points. In terms of how the SAGE is scored, so a score of 17 or higher is considered a normal cognition. If they score around 15 to 16, they have mild, and if they score 14 or less, then there's a suspicion for dementia. And we do adjust this for education and age, so those who are 80 or older, or if they did not graduate high school, they were given 1 extra point. So there are some examples of what the SAGE looks like. They ask you what's today's date. They ask you to identify certain visual objects. They ask you how to relate 2 abstract concepts together, how they're like. They have them do some mathematical questions, and then identifications, listing off stuff, and then seeing their visual spatial skills. So in our study, for us SAGE scores, preoperatively, it's around 2/3 of the people passed and 1/3 of the people failed with an average score of 17.5, so barely making the cutoff of normal. At 1 year post-implantation, around 58% passed, 41% failed, and then at 2 years, around 70% passed and 29% failed. But when you compare all them all together, there was really no significant difference in the SAGE scores between the same patients preoperative 1 year and 2 years. So the SAGE scores stayed relatively consistent. And you can see that in the graph form. The level of how many people passed and how many people failed, and an average SAGE score stayed relatively consistent. So now we talk about the speech recognition score. So preoperative-wise, when we look at all the word testing scores, they're quite poor, right? That's why they need a CI to begin with. So around 12 if you're looking at CNC, 18 if you're like EasyBio. But you see an immediate jump after your cochlear implant going up to the 50s and 60s, and that improvement in speech recognition scores held at the 2-year mark. So there was statistically significant improvement in the speech scores at 1 year and continued at 2 years compared to their preoperative scores. When you compare just the 1 year and the 2 years together, there was no statistical difference between them, so the speech scores held steady at 2 years. In the graph form, you can see the huge jump from preoperative to post-implantation and a pretty consistent steady rate between first and second year. So then we stratified these people by age. In the past, everyone 65 or older were considered elderly, but now with modern medicine and with better nutrition, better exercise, 90 is the new 70 and 70 is the new 50. So, you can't really put everyone over 65 in the same group. So we decided to separate the people over 60 into 2 categories, one from 65 to 80 and another 80, those people over 80. And when we divided them by age, we continued to show that their speech scores were significantly improved after cochlear implants at 1 year and 2 years. And there was no significant difference in their speech scores when you compare the 2 age groups, both at 1 year and 2 years. So if you look at the visual representation, everyone had a jump after cochlear implantation. And if you look, so the blue is the CNC scores for those 65 to 80, and the orange is the same word list, but for those over 80, and there was pretty consistent between the 2 age groups. So being older than 80 does not mean that you have worse speech scores. So then we divided by their SAGE scores and see if their cognition plays a role in their speech scores. For those who passed and those who failed, they both showed a significant improvement in their speech scores. So even if you failed, you still will have improved speech scores. However, when you compare those who failed and those who passed, the passed group, those without any cognitive decline, had significantly better speech scores compared to the people who failed the SAGE test at 1 year and 2 years post-implantation. So in scores here, you can definitely tell that the blue and the grays are those who passed, and the orange and the yellows are those who failed. And clearly there was an advantage in those who passed the SAGE scores and had no signs of cognitive decline. So based on, to start summarizing, CI and LA have been shown to improve speech cognition scores. It's been shown to improve the quality of life, their social interactions, their self-esteem. And both age groups, regardless if they're over 65 or over 80, benefit from these CIs with statistically significant improvement in their speech recognition scores that held steady even 2 years after a cochlear implant. The prior concerns that people had regarding the comorbidities and tolerance, they're becoming less and less of an issue. We've talked about newer innovations in CIs, smaller processors, shorter electrodes, more refined surgical techniques. And the key thing from this updated study is that those people who passed the SAGE test had significantly better performance than those who failed. So cognition is a preoperative cognition is a much better predictor of CI success than age. Now there are future things that we can do. Certain papers in the literature suggest that having a CI may benefit you in the postoperative setting, improving your cognition and decrease the risk of you developing dementia. Now to study this, the rate of the scores, the SAGE scores in a healthy population, unfortunately has not been evaluated, but there are certain studies that they actually measured the level of decrease in SAGE. So people with any mild cognitive impairment, they found that decrease around 1.9 points per year, and those with full-blown Alzheimer's, also something similar, also around 1.8. Now, we've shown that there was no statistical difference in our speech scores between 1 year and 2 years. Everything stayed steady. So this may indicate that having this cochlear implant may stabilize people's cognitive status. But in order to confirm that point, we do need a lot longer than a 2-year study for that to suggest that. So in summary, using the SAGE questionnaire is very affordable, it's very easy, can be easily done in any clinic, and it's a good way of evaluating your patients preoperatively for their cognitive status. And that can give you a good idea of how well they will do in their speech scores after a CI, based on and it's a lot more predictive than age would be. So, that's it.
Question? Yep, Michael?
Is that SAGE questionnaire available in Spanish or not?
I think there are versions, yeah. I think I saw a few in Spanish, some in French, and then it's easily convertible to because most of it is visual spatial, so you really are just translating the question to sandwiches.
Yeah, I think you can, Spanish for sure. It's just mainly the directions, because it's all really retracing the directions and redoing diagrams.
Yeah, but it still has to be validated, even if it's just the directions. So.
We don't administer it in Spanish.
Yeah. Most of ours are. And also, were you doing MOCAs on them as well? MOCAs? MOCA testing on them as well? Because it'd be interesting to compare. That's a more standard analytical test looking at cognition, or at least for dementia. So many, I don't know about other people, but I know our place and many of the big centers are doing MOCAs on everybody. So it'd be interesting to add that in as the second. It's another questionnaire, but it would be nice to compare the two.
Thank you. So I wanted to know if there is a score that tells me don't bother implanting this person. And I haven't found the answer to that. Because, we know that if somebody is cognitively declining, we would be doing them a service by implanting them, bringing them back to the world of hearing. And I think the factor that determines they are too far gone to benefit from a cochlear implant has actually been the family. Family says, don't bother, because they're not going to use it, and they don't even want to wear a hearing aid because they think that they're too far gone. Otherwise, anybody who has any kind of mental or cognitive decline and who needs a cochlear implant, if they have a good medical clearance, we would implant them with the hope that maybe we are stabilizing their decline and bringing them back to a better communicative level.
The SAGE test is available in 8 languages: English, Spanish, Italian, Dutch, Croatian, French, German.
Thank you, Julie. Yeah. All right, next is Dr. Kim. Kim and company are here to talk about cochlear implants in single-sided deafness.
Hello, good afternoon. It's a final stretch for all of us. My name is Christine Kim. I'm number 47, so I complete, I think, almost all the millennials that presented today. I currently practice at Albany Medical Center up in Albany, New York, and it's great to be back in Sarasota. It was a winter storm right before I came, so I wasn't even sure if my flight was going to make it. Dr. Poe made it down here, so. For today's presentation, I was asked to present a study that was conducted around the time of my fellowship, and it's entitled Benefits of Unilateral Cochlear Implantation in Adults with Asymmetric Hearing Loss. Myself, the co-authors, and the senior authors have nothing to disclose. The study was sponsored by Advanced Bionics. So in the United States, it is estimated that roughly around 18 million people suffer from single-sided deafness or asymmetric hearing loss. And with the loss of the benefits that come with binaural hearing, many studies have shown that this population experience diminished speech perception and noise, impaired sound localization, increased stress, anxiety, depression, and social isolation. And for those who experience tinnitus, which frequently accompanies hearing loss, can have further impairment. And traditionally, hearing rehabilitative options have included the cross hearing aids and the use of bone conduction devices. And while these options do improve speech understanding when the speech is presented to the deaf ear, they don't restore true binaural hearing. And Art et al. In 2011 was one of the first studies that compared cochlear implantation to these traditional options. And the study has shown that cochlear implant was superior to these options when it came to improving speech perception and noise. And since then, many studies have shown the benefits of cochlear implantation in this population, which ultimately led to FDA approval of CI in single-sided deafness in 2019. So our study was one of those studies, and the objective was to evaluate the benefits of unilateral cochlear implantation in adults with single-sided deafness and asymmetric hearing loss using audiologic evaluation and patient-related outcome measures. The study was designed as prospective within subjects repeated measure study, and subjects were recruited from 2 centers in the United States, and adults 18 years of age or older who met the audiometric inclusion criteria were included in the study. So for our study, the audiometric inclusion criteria for the ear to be implanted, the worst hearing ear, was severe to profound sensorineural hearing loss, which is defined as pure tone average of 70 decibel or greater, with CNC word score less than or equal to 30%. The duration of the severe to profound sensorineural hearing loss must be greater than 3 months and less than or equal to 10 years. And for the contralateral ear, it was up to moderately severe sensorineural hearing loss with CNC word score greater than 30%. And for those subjects that met the criteria, they underwent unilateral cochlear implantation in their worst hearing ear using either a high-res 90K Advantage implant or the high-res Ultra implant. Our objective measures included the standard pure tone audiometry, speech perception testing, including the CNC word test, and the AZ biosentence test and noise, as well as sound source lateralization test. And subjective measures included questionnaires, including SSQ, Glasgow Benefit Inventory, and Tinnitus Handicap Inventory for those who also reported history of tinnitus. The outcome measures were obtained at baseline and at 3, 6, 12-month post-activation. We had 24 subjects enrolled, and 14 of those completed the study. The mean age of the subjects was 51.7 years, with a range from 37 to 70 years. We had 3 males, 11 females. The duration of severe to profound hearing loss was 3.5 years on average, with sudden sensorineural hearing loss being the most common etiology, followed by Meniere's disease. So these graphs show the baseline air conduction thresholds of our subjects. On the left side is the worst hearing ear, which is the ear to be implanted, which showed mean pure tone average of 94.4 decibel. On the right, we have the contralateral ear with a mean pure tone average of 26.2 decibel. And the baseline pure tone, the baseline air conduction thresholds were also repeated at activation as well as 12-month post-activation. And on the right, it shows that the thresholds remain stable for the contralateral ear throughout the study period. And this shows the CNC word score. At baseline, our subjects had a mean CNC word score of 2.3% in the ear to be implanted, and this significantly improved to around 60%, which persisted through 12-month post-activation. For the AZ biosentence score in noise with signal-to ratio of 5 decibel, we had 3 conditions, and these were done in the subject's everyday binaural hearing condition. In the first condition, the sentences were presented from the front as well as the noise, and our patients at baseline scored 87.2%, which did increase to 91.2%, and this increase was statistically significant. In the second condition, the sentences were presented from the front while the noise was presented to the better hearing ear. And at baseline, we had 86.1% as the score, and we didn't see any significant improvement to any of the 3 follow-up time points. And for the third condition, we had the sentences presented from the front while the noise was presented to the worst hearing ear, which is the implanted ear. And as expected, compared to the other 2 conditions where the speech and the noise were either co-localized or the noise was presented to the better hearing ear, subjects did better in this condition, 91.8% at baseline. But again, we didn't see any significant improvement to any of the 3 follow-up time points. But it is important to note that cochlear implantation in the worst hearing ear did not adversely affect the performance of the better hearing ear. And for the lateralization test, this was done in a sound field with the subject positioned face forward and centered between 2 speakers, which were located at 45 degrees and about 1 meter distance. And the AZ biosentences were presented through either the left or the right speaker, and the subject was tasked to identify the direction only. At baseline, the mean score was 71.3%, which did significantly improve after cochlear implantation. For SSQ, as the graphs show here, we did see a significant improvement in all subdomains. And Glasgow Benefit Inventory, as you know, is a validated questionnaire that looks at the patient's health status after a certain intervention. A positive score means better health because of the intervention, whereas a score of 0 means no difference, and the negative score means worse health status. And at all follow-up time points, we had positive scores. And when looking at the 12-month individual scores, 11 out of 13, so we had 1 missing data point there, but 11 out of 13, the majority had positive scores. We had 10 subjects that also reported tinnitus and completed the THI questionnaire, and we had a significant drop in the mean THI score for all the follow-up time points. And again, looking at the individual scores at 12 months, 8 out of 10 had clinically significant drop in their THI mean score, whereas 7 out of 10 had what's called super response. That's defined by Zeman et al. So in summary, our data shows that the unilateral cochlear implantation in adults with asymmetric hearing loss can lead to increased speech understanding, improved sound lateralization, improved tinnitus perception, and improved quality of life. And it adds to the body of literature that exists demonstrating both of these like objective and subjective benefits of cochlear implantation in this particular population. Some of the limitations, number 1, small sample size, which can increase the risk of false positive and overestimation of our statistical results. Like I said, the AZ biosentence test in noise was done in a everyday binaural listening condition for these subjects, so the better hearing ear was not masked. And so one can argue that this isn't as useful for tracking post-CI performance over time. But the intent here was to exemplify the subject's everyday listening condition and to gauge the overall performance. And with the same token, lateralization task may have been too simple compared to some of the true sound localization tasks. And we did have a few missing data points, and for our statistical analysis, these missing data points were assumed to be missing at random. I think that's everything. Thank you.
So before we knew what we know now about single-sided deafness cochlear implants, we used to implant everyone with a Baha, with single-sided deafness, or a cross. And now with more and more experience from our own experience and from others around the world, I think it's a no-brainer that a cochlear implant is the better answer for single-sided deafness as long as there is a cochlear nerve. So we're not doing it in an acoustic neuroma case where the nerve has completely been eradicated. The limitation here is insurance coverage. So if you happen to be Medicare age, we don't open that discussion with you unless you're independently rich, because Medicare will not cover single-sided deafness cochlear implants. But for patients who have private insurance, we send in a request with the letter and the data and ask for permission to do a cochlear implant in a single-sided deafness. And more often than not, it's been approved. So all of our experience, in addition to this, and we've done tons of those after this, have been approved by insurance and paid for by insurance in single-sided deafness. We were afraid that doing a cochlear implant will not work or will confuse the opposite ear. Well, it has not confused the opposite ear, and it works, and that's not thanks to us, it's thanks to our brain. The brain has a tremendous ability to make sense out of whatever is thrown at it, and its ability to combine the electric hearing from a cochlear implant to the natural hearing from the opposite ear is the reason for our success. I think we have a few minutes for a discussion before we move into the next section. Right? Right. So, any questions, comments, discussion, opposition? Eric.
I share your enthusiasm, but I don't think that your conclusions are completely unqualified. I think the most relevant piece of data, which I rarely hear presented at conferences, is how many unilateral cochlear implant recipients are actual users a year or more down the road. And I don't know. I think that the parameters that we use to measure cochlear implant performance are not real-world parameters. They're laboratory parameters that are done in audiometrically controlled setting. And I think that the population of people who qualify for unilateral cochlear implantation, by and large, are people who've had sudden sensorineural hearing loss and fail to respond adequately or significantly to medical interventions, and they're looking for appropriate answers. But that's quite different than a person who has bilateral progressive sensorineural hearing loss, has used hearing aids, has adapted to deafness for a long time, and has more to gain from cochlear implantation than that category of person that I just described. And I think that these things are difficult to measure, but they're significant factors beyond cost.
Thanks for your comments, Eric. You're always very thoughtful in whatever you say. I know of one patient, actually, who stopped using the cochlear implant. She says, I don't think it's helping me, and I'm not going to use it anymore. The rest of them are happy users. Sharon, do we know of how many people are not using the single-sided deafness cochlear implants?
We haven't really put together a study, but I would say that if you look at single-sided deafness with our bone anchor device users and that have been long-term single-sided, that they tend to become non-users more frequently than our single-sided deafness patients that are now using cochlear implants. I only can think of the one that's a single-sided deafness that is a cochlear implant user now that isn't using it. They're more challenging to get programmed and ramped up to get to that successful point because they are hearing out of that ear and you're training it just like a cochlear implant ear. But I think their success is better long-term than the single-sided that have been deafened for a long time using a bone anchor device. If they're more than 10 years, they often become non-users.
See, that was my concern in the beginning, that because they have a normal ear, why would they accept a cochlear implant kind of hearing, comparing it to their normal ear. They're more challenging patients, but they're happy to use it. And the biggest difference between those patients with CI SSD versus the Baha SSD is sound localization. That's the single most advantage over Cross or Baha if we bring them hearing to the deaf side. Dennis?
Well, as one objective measure, do you keep track of your user logs for time of use per day? Well, right, but that would be an objective measure.
Yes. Yeah. Dan Chu.
So Dennis, you brought up the exact point. So our audiologists pay a lot of attention to the data logging, and it's this self-selecting thing. If your data logging is much higher, your compliance and benefit is much higher, whereas if you're a poor user, then you don't. It's not causal, I don't think. I think it's part of what Sharon was talking about, just whether your brain locks onto it and bonds with it or not.
Age? Well, I mean, we didn't look at age specifically in the single-sided deafness population, but our experience with age in the cochlear implant population, probably would still apply, that cochlear implants do well at any age. Any other questions? No? I guess it's your turn, David. David's title was too long to put into the little square. So, primum non nocere, etc., etc., etc. But he'll tell us what the rest of the title is.
First and foremost, it's wonderful to be back. I was fellow number 8, and to put that into perspective, 35 years ago, this June, I came to be with you. Last night, I had an extraordinary opportunity to meet fellow number 48, Dr. Fechner, and she pointed out very tactfully that there were 40 fellows between us. You, sir, have spawned an amazing family, and we were here to express our gratitude and appreciation for everything you've done for us and for humanity. It's always been said that the later in the day you speak, the more likely you are to be in the way of the cocktail hour, so I'll be as brief as possible. Okay, technology and I don't get along greatly. Everybody always wondered where Tulsa is, so I had this slide made years ago. Tulsa's right there, right in the sort of dead center of the United States. This is great when I go overseas because everybody knows where we are. So my talk is in 2 parts. Primum non nocere, temporal bone surgery, ipsilateral to the only seeing eye, and then, for a few moments, musings on facial nerve monitoring. Case report, 75-year-old gentleman, chronic draining ear on the right, mixed hearing loss. On exam, he had an attic cholesteatoma, and he was blind in his left eye. In fact, he had a glass eye. CT showed evidence of the cholesteatoma thinning the tegmen. So, unfortunately, I was in a position where I felt that I had to do something to address this guy's disease. This was not something I could temporize with anything. Audiogram, standard mixed hearing loss, nothing extraordinary. The day of surgery, the patient's daughter, who I met the day of surgery, was a nurse, and she had done a Google search on risks of chronic ear surgery, and she goes, "How about if my dad loses his facial nerve function on the side of his only seeing eye?" So we discussed the risks of facial paralysis, we discussed the risks of vision loss, and I really thought, wow, what are the risks of vision loss with facial paralysis? So this always comes up where I encourage patients not to confuse their Google search with my medical degree. My son actually has one of these, and sometimes I wish I did too, especially with patients. So I reviewed the the ophthalmology literature, facial plastic literature, kind of murky, mainly because nobody that has a great, large experience with facial nerve paralysis seems to want to talk about it. You know, and so it's always little small studies here and there, not a lot of numbers. The incidence varies from 30% to rare, but rare is still a lot bigger than none. Interestingly, the risks double with loss of corneal sensation. So this is a big concern in skull-base surgery or in situations where cranial nerve 5 may be involved. And subsequent to this experience, I've been checking the corneal reflexes on other patients where I have been doing the same thing, operating on their dominant seeing eye or only seeing eye. Primary goal is to maximize facial nerve protection. Sometimes you come up with it, is it really their only seeing eye? You know, how often do people come in and say, I have a dead ear, and we test it, and they still have a lot of cochlear reserve? Sometimes it's just cataract or vision loss. Ophthalmology, oculoplastics, almost are always involved with these patients. And if it's a really high-risk situation, I tend to involve them early on because after surgery, misery loves company. And if you have them on board early, particularly with addressing the status of the seeing in the other eye, or be available, or understand the limitations of what's available if you have a problem, and if there is a problem, early post-op intervention, aggressive post-op intervention is very important. Surgical approach, this would be a time to be subtotal. This would be a time to be conservative. If you're having residents or fellows, this would be the time for you to sit in the pilot seat and let them watch, because this is high stakes. This is a high stakes operation. But the sine qua non of all this is facial nerve monitoring. Preoperative evaluation, I stress this, you've got to check the systems for functioning, you've got to check for paralysis. If you've never seen a case of pseudocholinesterase deficiency, it's relatively rare, 1 in 2,000 to 1 in 5,000, but I've seen a couple of cases of it, and a couple of times it was not a good situation. History of previous surgery that went great, not a good indicator, because if they had a long or prolonged surgery, they'd have had time to metabolize the paralyzing agent. Not a guarantee. So if they have a history of having some other previous operation, unless it was a very short operation. And a big red flag is if they tell you they had trouble waking up or if they had to be on a ventilator for a long period of time. Always getting the patient ready. If it's high stakes, I use both systems. I use both the NIM and the S8. Actually, I prefer the handpiece to the Silverstein over the NIM. I think it's easier to use, it's easier to adjust. The NIM handpiece actually has a sharp tip on it. And so whenever I have a high stakes case, I use both. One of the essential things to do after you have the systems on and checked and make sure they're working well is just check the patient yourself to make sure they're not paralyzed. Can't tell you how many times people have been amazed to see me do this. In fact, I recently had one of the medical equipment company people in, and they'd never seen anybody do this. And just what you do is you take the stimulator that the anesthesiologists use to check for paralysis and just check the facial nerve function. It takes seconds and document it in the chart. Paralyzed patient. So you're in the middle of surgery and you have anesthetica interruptus. That's where the patients, or they switch out anesthesiologists. Particularly frustrating, in a big medical center or later in the day, and the patient gets paralyzed. The other is local. During pandemic, we had trouble getting lidocaine, and I personally had an experience where they auto-substituted, without telling me, bupivacaine for lidocaine, and I experienced a patient with prolonged neuropraxia. Patients that have a history of a stroke or Bell's palsy will always have a reduced response. So if you have a history of somebody having a Bell's palsy in the past or a reduced response, they will not respond very well, to intraoperative stimulation sometimes. And then the other is, if you're ever in the middle of a case and you lose stimulus, stop, take a breath, get some warm saline, warm LR, whatever you got, and just warm the nerve up. I can't tell you how many times that's made all the difference in the world. Local anesthetics, Always comes up. Somebody comes in and says, well, I'm allergic to lidocaine, or I can't do this, or I can't do that. In high-risk situations, I just wouldn't use them. I mix up my own low-dose epi on the back table. Now, I know this is controversial. Some places it's absolutely forbidden. If your pharmacy won't do it, just do it yourself. You get 1/10 of a cc of the epinephrine, injectable epinephrine from the anesthesiologist. They have it on their cart. If not, you can get it from the crash cart. And you put it in 9.9 cc's of normal saline, but don't use the topical epi, the one that we put in the ear. You get the stuff that comes out of the vial. So patients that have only seeing eyes, to me, this is a matter of awareness, it's a matter of preparation, and a matter of communication, but specifically awareness. I don't think I had ever given this a single thought until this guy's daughter just quizzed me on the spot, moments before surgery, about what were the risks. And needless to say, it's been on my mind since then. Now, musings. This is why I had to do 2 talks, but Jack only gave me 1 slot. In the fall of 1983, I was a senior medical student at Vanderbilt University, and it was very interesting. Vanderbilt did not have an otolaryngology department, so just kind of crazy to think about that. So I went and spent time with Mike Glasscock, an extraordinary guy, and he was doing acoustics and glomas, just, no facial nerve monitoring, or maybe just a little handheld stimulator. I mean, nothing, very serious, nothing consistent. Matched for ENT, went to UT Houston and spent 5 years with Bob Jarsdorfer, another wonderful guy, God bless both their souls, who did atresia surgery. Dr. J was doing atresia surgery without high-resolution CT scanning, and he was doing it without any facial nerve monitoring. And I'm just, in retrospect, was just like amazed that this guy had that skill. So get my fellowship, get in the car, drive up from Houston, start here. Herb introduces me to the S8, which they were developing and working on here. The EMG was coming along. To me, I thought this was the answer to a prayer. And my God, I'd seen all this other stuff go on. This is what we needed more than anything else. They had courses on it at the AAO and the ANS. This is a great slide because September 10th, 1990 is my wife's 30th birthday. And where was I? Not with her. I was giving... She was up in the room, but that's how important it was. We were giving courses of it. It was part of the core of what we were doing. But boy, it was not all kittens and cupcakes. It was not universally widely accepted. I personally heard the following things with my own ears. It's a crutch. You shouldn't operate if you can't find the nerve. It's a sign of weakness or poor skills. And my favorite is, done hundreds of cases without using a monitor, okay? It is now core curriculum at the AAO and part of the training. I don't know if any of you saw the ANS meeting that we had online a while back, but Jack Cartouche, Herb, I don't know if you saw it, but Jack Cartouche gave you a great shout out because you and Jack were really the forefathers of all this. And both of you took a lot of abuse and a lot of challenge to make something that is just, I cannot imagine anybody getting up in a meeting right now and saying, oh, I've done hundreds of acoustic aromas without, any facial nerve monitoring. It was particularly hurtful for all those of us at Team Silverstein because, again, when I came here, to me, this is like the answer to a prayer. And we all, everybody in the academy, everybody across the globe owes you a great deal of gratitude. Last little slide. This is a blast from the past. When was the last time you saw one of these, Herb? For the children in the audience, and by the way, I really appreciate Dr. Young's comment about multi-generations. As a baby boomer, it really hit home. And then I realized that I probably have kids older than you guys. I definitely have shoes older than you are. In the day and the time when I was here, you had to inform Medicare patients if you didn't take assignment. And we at the time were billing for and receiving a modest additional sum for facial nerve monitoring. And interestingly, somewhere along the way, the insurance companies, the Medicares, the Medicaids all stopped that. And there's a real move right now, I think, back at the ANS and AOS level to get this back covered because this is an important part of what we do. And I think, again, it goes back to you getting up and many times standing before a lot of people that didn't agree with you, but quite frankly, you have proved them all wrong. And thanks. Well under my time for a long topic and long title, and I'll take any questions. So how much time do I have left? Because I was going to do a little stand-up just in case. 2 minutes. What happened to my sleepy little Sarasota that I came to, 35 years ago? This place is just, God, I couldn't believe what's going on. It's like a real city.
Thank you, David. And thanks for introducing the subject for our next speakers, because now we're going to talk about facial paralysis. What do we do once we face it? We don't like to, but we have to. So we have two people next to talk about how to manage facial nerve paralysis. Dr. Ein from University of Miami, and Laura Wazin from Silverstein Institute and FPG. They've been working together as a team in the management of facial nerve paralysis, either after surgery or from unresolved Bell's palsy and the likes. So, Dr. Ein?
Thank you. Thank you so much for inviting me. Obviously, I don't have a number. I'm not even an otologist, so bear with me. I did my ENT residency at Miami, and then I did my facial plastics and reconstructive training at Mass Eye under Tessa Hadlock. So I'm now back at the University of Miami, essentially starting up a facial nerve center, and so facial paralysis is mostly what I do. Today, I'm going to be talking about facial paralysis kind of in the setting of after like a skull-based surgery. So here's a patient that I saw very early on. I promise my photography skills get better. She is 30 years old. She had a history of vestibular schwannoma that was previously resected, treated with Gamma knife, and then she underwent a left translabyrinthine approach for partial resection. Facial nerve was preserved intraoperatively, but she woke up from surgery with a House-Brackman 6 out of 6. So there's one of two things that are going to happen for her. She's either going to recover or she's not, and then she's going to need some reinnervation surgery. We'll kind of talk about both of those situations and how we treat them, because there's a lot of things we do for both situations. So this is essentially my whole talk in one slide. And we'll kind of keep going back to this, but in the immediate postoperative period or in the acute setting, you want to obviously do eye care. Some people are going to require an eyelid wait, some people won't. And education and managing expectations are extremely important in these patients, because it can be a very long recovery process, and obviously it takes a large mental toll. So if you do notice that there is spontaneous recovery, then it's very important to evaluate for synkinesis during that first year and to start with physical therapy. And this is just a reminder, I know we all are very familiar with the House-Brackman scale, that the synkinesis is part of this scale, where just barely noticeable synkinesis is a House-Brackman 2. And you almost have to train your eye to start to see this. Obviously, like a level, a House-Brackman 4 with severe synkinesis is much more obvious. I start synkinesis Botox. I start functional Botox for synkinesis when they're 1 year post-op, but you can start some contralateral Botox right away, just to kind of help them get through the recovery period. And I think that education is really important. So these are the slides that I show my patients in clinic. And obviously, we're all familiar with the anatomy of the facial nerve. I show it to them, as it travels through the bony channel, as it then branches through the cheek and then eventually hits the muscles of facial expression. And I kind of go through these muscles with them so they start to understand why, whatever is happening with their face is happening. And then we go back to this picture and say, okay, your surgery was in this location, and while that facial nerve, is intact, There are legs or axons within that nerve that can be injured. We have varying degrees of injury, from mild injury where there's just some inflammation to more severe injury where those axons get damaged. And the good news is that those axons or legs of the nerve can recover, but they do so in an abnormal fashion. So like a starfish, if you were to chop off one of its limbs, it would not just grow back one, it would grow back two. Each axon has up to 20 growth cones. And so if you have 7,000 axons in your nerve, in the worst case scenario, you could have 140,000 growth cones trying to make its way down a one-lane highway, and you end up with a traffic jam, which is why it takes so long for for your face to recover. And eventually, some of these are gonna peel off and die off, and some are gonna make their way through the mess back to the face. So then I show them this, I say, okay, in a normal situation, very simplified, if you have blue fibers that go from your brain to your eye for blink, and red fibers that go from your brain to your mouth for smile, then in the acute setting, whether it's Bell's palsy or after surgery, there's no conduction going to the face. And this is when you can't blink, you can't smile, that's that flaccid state. As these nerves start to recover, there's no road sign saying like, eye, come back to the eye, or mouth, come back to me. And so cross-wiring happens. And this is really what facial neuromuscular retraining is aiming to help to rewire some of these connections. But then the other thing that happens, like we talked about with those growth cones, is that you could end up with an eye fiber that makes it back to the eye, but now also is sprouting to the mouth or the chin or the neck, and this is happening throughout the whole face. And this is the basis of synkinesis, where you have involuntary contraction of one muscle that happens with voluntary contraction of another muscle. And then to make matters even worse, the nerves don't know when to stop recovering, and so they overgrow. And that's what leads to this hypertonic state. So the face that used to be paralyzed, the side of the face, is now hypertonic and spasming. And this is really the reason why we recommend against any type of electrical stimulation during the recovery period, because the thought process is if you electrically stimulate the muscles, they'll secrete more neurotrophic factors, which will attract more neural ingrowth, which is actually not what we want. So here's an example of a patient with very severe left non-flaccid facial palsy. Again, this develops after in-continuity facial nerve insults. Most commonly, I see this after Bell's palsy, which happens in about 15 to 30% of patients, and can also happen after various other conditions. And we have our whole reconstructive ladder for this, and it really starts out with targeted facial neuromuscular retraining and Botox, and they work synergistically together. Then we layer in selective myectomies and denervations, which is a whole nother talk that we're not going to get into. So you're going to hear a lot more about the role of physical therapy, but I'll just show you one example of one of my patients, and this is just before and after with just PT. And so you can see that she's got way better facial balance and harmony. Obviously, she's got left-sided non-flaccid facial palsy. She was after Ramsey Hunt. And then, again, functional Botox is super important for these patients. And here are some of the locations that I would treat on the paralyzed side of the face. Getting orbicularis oculi, mentalis and platysma are very easy places to target that you get like immediate relief from. So now we'll switch gears and talk about the different types of reinnervation and when that's indicated. And there are essentially 3 different flavors of nerve transfers. The cross-face nerve graft, the goal of that one is just for a spontaneous smile. And we don't have any particular timing that needs to be done for this, but it is a 2-stage surgery. So we typically would tack on the first stage with another procedure. The 5 to 7 transfer, or masseteric to facial nerve transfer, the goal there is a voluntary smile. It's a bite-driven smile. And we do that at 6 months post-op, and we'll go into that in a second. And then our 12 to 7 transfer, we wait until 12 months, and it has it used to be a little bit more in vogue. It has a little bit more boutique applications, and we'll kind of go through that also. So our patient came back, and at 6 months, she had absolutely no twitches on exam, and so we talked about doing a 5 to 7 transfer and that first stage cross-face nerve graft. And the reason we do this at 6 months is because essentially this paper came out of Otology and Neurotology in 2011 from the Hopkins groups, where they did some predictive modeling for patients for facial nerve recovery after vestibular schwannoma surgery. And what they found was that if you're still about a House-Brackman 6, around 7 months, then you have a very high probability of having a poor outcome. And so the way that we interpret this is that essentially, if by that point we don't see any flickers, even if that nerve is to recover and give tone, we're not going to get a meaningful smile. And that's really what we care about. We don't really care if the cheek twitches. We want to see someone smile and have someone walk down the street and be able to read joy and the appropriate emotions for smiling. And so that's why we do earlier intervention just for that 5 to 7 transfer. And here's what we do. We essentially flip out the masseteric nerve from the masseter muscle and co-opt it end-to-end into a distal zygomatical buccal branch that's only supplying the muscles of smile. So that means that the rest of the facial nerve and the remainder of the branches are still all intact and can still hopefully get recovery through that main trunk. And here are just a couple of examples of patients I treated in fellowship who had really nice outcomes from their 5 to 7. Intraoperatively, this is what it looks like. We do a modified facelift approach. We have some good landmarks using the zygomatic arch to find the the recipient facial nerve branches, which you can see in the bottom with the blue loops. And then we can flip out the masseteric nerve from the muscle. Sometimes we can preserve an anterior branch to keep some movement of that muscle, but if you take the whole thing, it's no problem. And then do an end-to-end coaptation. And then here's our patient several months later. I think she started to get twitches through her 5 to 7 transfer about 3 months post-op. This was probably about 7 months post-op where we asked her to bite down. And you can see that she has a more meaningful smile. It's not a perfect smile, but it definitely conveys the emotions that we want it to. Again, as I quickly mentioned, the cross-face nerve graft is done for a spontaneous smile. So while that 5 to 7 is a voluntary smile, it's very powerful, it has high success rates, it's not natural. You have to learn how to use it. And so we place the cross-face nerve graft to try to get spontaneity. And in that first stage, what we do is we open up the not paralyzed side of the face and we stimulate distal zygomatical buccal branches that are stimulating the smile muscles. And so in this video, I'm using the checkpoint nerve stimulator. I'm stimulating the donor branch. And so you'll see that this is it's doing upper lip elevation and cheek. And we choose the branch that we think would be firing when someone's laughing. And then obviously we make sure that we preserve collaterals. And then harvest a sural nerve from the ankle, usually through a small incision. We can harvest up to 30 centimeters, and then we tunnel it across the face in a minimally invasive way and bank it for a second stage, which is usually a very small gracilis muscle transfer for a spontaneous smile, which she actually just went through. And so the last kind of part of this is, on the reinnervation side, is what happens after this. So essentially, she then came back after 12 months, and she still had no recovery in the rest of her face other than what we had achieved through the 5 to 7. And so this is when we start talking about the 12 to 7 transfer. And classically, the way that it used to be done was the hypoglossal nerve was cut in the neck and then swung up superiorly to get co-opted end-to-end to the main trunk of the facial nerve up in the face. And as you can see, this is a patient from Mass Eye and Ear about 25 years ago. She's got good tone, but her smile is not very meaningful. She's got like that classic downturning of her oral commissure or frozen oral commissure. And she's got mass movements, hemitongue atrophy, and synkinesis. And so sort of the newer way of doing this is doing a split hypoglossal to facial nerve transfer, where we leave the hypoglossal nerve in continuity and cut just about 30 to 40% of those fibers, and then hook up the main trunk of the facial nerve to it. So here's a video I took in fellowship with one of my mentors, Dr. Jowett, where we're opening up the epineurium, and then we use a cutting needle to cut about 30 to 40% of the nerve. And then there's 2 ways that you can then hook up the facial nerve. One, you can cut it at stylomastoid foramen and use an interposition graft. Or the way that I like to do it, and the way I did it on this patient, is have one of our otologists drill out the mastoid and cut the nerve at second genu and swing that down into the neck. And that way you only have one coaptation site, because you do lose axons at each coaptation site. And so here she is immediately post-op. You can see she's got good tongue function because we are still sending a lot of those axons to the tongue. And, you know, at rest, she's got better tone. Her, you know, eyes are a little bit more symmetric. She's got some better tone around her nasolabial fold, not perfect. And when we ask her to push her tongue against the roof of her mouth, you can see that there's activation of her oculi, you know, some mid-face, DAO, mentalis, and platysma. And so, you know, this was a success in that we got the muscles to wake up, but now is, you know, these aren't necessarily natural movements, and that's really where having a physical therapist who understands all of this and who can work with these patients to relearn how to use their face is so important. And I've been very, very lucky that when I first got here, I was introduced to Laura so that I could, and we started teaming up and working with people, and it's really been a huge help to my patients. So with that, I will have her come up and talk to you about the importance of all of this training.
Okay. Okay, I just want to see how to advance these slides here. Okay, very good. So that was amazing, great. I'm going to pick up where she left off and talk about what did I do with this patient. So the illustration on the left shows the first day I met her. I'm looking at her face. I'm seeing that the symmetry is really off. Because she hasn't had normal movement on the left side of her face, the right side has really been unopposed, and we can see the strong pull of the face to the right of her mouth and her nose. So the problem is that as the left side is waking up, now the right side is tight. So that tightness can inhibit the movement that we're hoping is going to start coming through. The approach I took was we first have to massage the muscles on the normal side of the face. We want to teach her how to be able to consciously relax those muscles on the right side of the face and learn how to actually dampen the excitement or animation in her face on the normal side. Another compensatory strategy is teaching her how to communicate in other ways besides facial expression, such as nodding your head in agreement, or using more body language to communicate active listening. So what were the outcomes with her facial symmetry? Well, I first met her on July 6th, and by using these different techniques, you can see that the symmetry of her face was improving a great deal. So now, part B, let's teach her how to use that biting smile. So my initial goal was just to teach her how to engage her bite. I didn't care what it looked like. All I wanted to see was that she was able to start getting movement on the affected side. After that was achieved, then the secondary goal comes in. That looks great, but how can we make it better? So some different strategies were she needed to learn how to relax her face more on the right side so that when she did start to smile, that the two corners of her mouth would start the movement at the same elevation, I guess is the word I'm going to use. After that, we wanted to think about symmetry by the normal side having to learn that the affected side can only smile so much. So if you want symmetry, the normal side needs to try to only smile as big as the affected side is able. And also, we want the movement to be moving simultaneously on both sides. So she had to learn how to time it. We didn't want the normal side shooting up quicker than the affected side was able. And of course, people, when they're communicating, they notice change in the person they're observing's face. So we wanted her to be able to finish her smile more simultaneously. The first thing we worked on was the small smile. I always like to focus on symmetry because I think that that is what makes them feel more normal to the observer and improves their self-esteem. And as she got better and better at her small smile, then we tried to move forward with a bigger and bigger smile. her homework was to start using her smile. Initially, she could use the mirror to kind of understand that her face is moving, but we don't want her to be dependent on the mirror. We want her to start using proprioceptive cues in her face on both the affected side and the normal side so that she can gain confidence and know exactly what her face is doing when she's smiling. Her homework was initially that when she went to the grocery store with a stranger who she could care less about, that she was supposed to, when the person gave him the money after she did her exchange, she was supposed to say thank you and smile. That was her first homework. Then she was supposed to start using her smile with friends and family, where she felt comfortable that she knew she was loved no matter what her smile looked like. And then as she improved, she was supposed to start using it in work settings and other types of settings. Some patients, not all patients, can progress to a more open mouth smile. I realized this when she was able to do like an isometric movement. She was creating the biting movement, but she wasn't actually pressing her teeth together. So she would just open her mouth a little bit so that there was, so that we could see her teeth, and then she would kind of make that biting motion without pressing her teeth, and voila, we start seeing an open mouth smile. Once that was happening, then we started looking at symmetry, because on the right side, which is her normal side, she naturally had a little bit of depression of her lower lip, which was creating asymmetry. So I was trying to teach her to relax her lower lip and just engage her smile by creating that rosy cheek, and that's how we tried to improve her symmetry with that type of motion. Another thing is it's nice that therapists get to work a little bit longer, with our patients. My sessions are about 45 minutes. So one day she came and we're doing Zoom here. She says, I think something's wrong with my face. I said, well, what are you talking about? She says, well, when I'm doing my biting smile, I think my eye is squinting, okay? But what she was really feeling is that when her biting smile is not engaged, her face was kind of flat at that time. And when she does her biting smile, you can see that the cheek starts to rise. And actually, what she perceived as a problem, she actually had better symmetry in her eyes when she did her biting smile. These are some of her outcomes. So like I said, I saw her first in July, but by August 31st, you can see some of the improvements she made in her closed mouth smile and also her open mouth smile. Not all of my patients need surgical intervention. The key components of neuro retraining are really these 6 concepts, but I don't have time to talk about all of them today. Thankfully, Dr. Ein highlighted the fact that if somebody's using electrical stimulation on their patients, it means that they're not up to date with what the current standard of care is and that it could be making their patients worse. I always look at it like this. I can never superimpose normal appearance or normal movement on top of what is abnormal tone or tightness. So I start with the face at rest. This is the first time I saw this lady. She had left Bell's palsy 4.5 months ago. So what do you see? Her eye is wider open, her mouth is pulled laterally and upward. What is she complaining about? She's complaining bitterly that her eye is dry and a really uncomfortable pulling sensation in the face. She also complains that she has a lot more pain and tightness in her face in the mornings when she first wakes up, and she's very worried that her smile isn't what she wants it to be. So what do? Well, I started out with massage techniques to the face. The goal is to dissipate stiffness that's in the face and also trigger points and to restore more of a symmetry and resting tone. So I give this illustration to the patients and I literally teach them how to massage each and every muscle correctly. So the mid-face, this feels good to do this, but it's not very specific. So we really teach our patients, the right way to massage the face, which luckily in the mid-face, you can put your thumb inside your mouth and then your finger on top and actually stretch or pull the entire muscle to create better symmetry. The results are decreased pain, and also the patient is finally doing something that they feel good about and they're seeing improvements. and we're moving them towards more patient autonomy and how to manage their condition. The second thing I thought when I saw this lady is, what's going on with her eye? Are there restrictions to movement? Can I teach her how to contract the orbicularis oculi muscle better? Is dryness, which she's complaining about so much, part of the problem in contributing to her synkinesis? And how can I teach her to inhibit unwanted movements of the face? I instructed her in an upper eyelid stretch. And not only does it stretch the soft tissue of the eyelid, but if your eye is wide open for a long time, then the levator palpebrae muscle can get very, very tight. So that even when they start to close their eye, now they have the muscular restriction of the palpebrae muscle. When you do this stretch, the patient notices, you can measure it if you like, at least around 2 to 3 millimeters of improved eye closure. The eye is not as tight, so it's easier for them to close their eye. Because it's easier for them to close their eye, they're less likely to generate synkinesis when they do try to close their eye. We teach them daytime management techniques. That was huge for this person. We also teach them ways that they can improve their nighttime eye management, because she thought since her eye was moving a little bit that it was okay at night when she was asleep. The picture shows how I teach patients to tape their eyes shut. That actually isn't tape. That's from, press and seal Glad products. You probably have it in your kitchen that you use to put over your Tupperware bowls. It's very lightweight. It comes off very, very easily. It doesn't tear the eyelashes out, and patients seem to like that a lot. It also creates a good seal. You can put your sleep mask over it if you like to add extra security to that. Here's another product that they could use if they wanted. So improving active eye closure. I think a bad thing to tell patients is to close their eye as tightly as they can, because then they're going to create this mass movement pattern. And if they have synkinesis, then we're just practicing synkinesis. Also, a blink is a very gentle and selective motion of the face. I also don't tell the patients to chew gum because, chewing gum is a different activity, and specific is terrific when you're practicing movements of the face. I ask them to do a gentle eye closure followed by a small press of the eye to see if they can get even more eye closure, but without drawing in the muscles of the midface, just trying to work the muscle of the eye. I ask them to look down, which helps them in overcoming the doll's phenomenon, which can be kind of disfiguring and noticeable. So what helped this patient? Well, recognizing that the tightness she had in the morning was because of not taping her eye at night, and that she needed to use lubrication. She needed to do massages before bed and in the morning, and also moist heat helped the face to relax. I taught her the massages, we worked on the daytime eye protection, and then she began with her neuro retraining. This is how much she improved in a short amount of time, just looking at her face in repose. She felt so much better about her appearance, and that there were things that she could do to get better. Her gentle eye closure also improved. It's still not perfect, but it's better than it was, and you can see that her synkinesis is less. She's not trying with all of her might to close her eye anymore. She's just really trying to use the orbicularis oculi muscle. And even with tight eye closure, which we can see she's closing her eye all the way, yes, she still has synkinesis, but it's not as strong as it was before. So what do we do about synkinesis with neuro retraining? Well, I tend to see two types of patients on day one. The first one is the person who's really aware of their synkinesis, and they're not happy. They will tell you every little thing that is wrong about when they close their eye or when they move their mouth. Or I see the person who is like totally oblivious of their synkinesis. In fact, they will swear up and down that they're not an inch better than they were from day one, and that their face is completely paralyzed. The person who is aware of their synkinesis usually can kind of fast track getting into the neuro retraining exercises. However, if you have a patient that's really, really angry, sometimes that can be a barrier to learning. So they may need a good referral to someone to help them to manage the feelings that are very significant that they're feeling. The person who believes their face is paralyzed, well, what do you do? The first thing is I teach them, no, no, no. Paralyzed is what you were week 1, when you couldn't close your eye at all, when you were drooling. Remember that? You couldn't drink. You couldn't manage food in your mouth. Your face was hanging. Then we start comparing the affected side and the normal side. The massage helps with that because then they start realizing how much tighter the affected side is, and also that they have trigger points that are painful. And then I have to guide them to understand the particular manifestation of their synkinesis, and we do this through guided therapy techniques. So let's take this guy. This is the first time I saw him. He's also one of Dr. Ein's patients. He has a really nice small smile, but he doesn't know what to do about his open mouth smile because it's still crooked and lopsided. So first of all, he had the myth that his face was paralyzed. So I had to reassure him by showing him that yes, no, he has movement in all parts of his face. Why do I say we have to dispel this myth? It's because of the patient's state of mind. If they believe that their face is paralyzed, then the next thing they believe is that their muscles are weak. And then the next thing they believe is that if they only contract their muscles stronger, then everything's going to start moving in a normal way again. The fallacy of this type of reasoning is that they're going to try to make stronger and stronger contractions of their face, which are going to cause mass movement patterns. It's going to worsen their synkinesis. They're going to have more disfiguration of whatever expression is that they're trying to make, and they're going to get more and more frustrated that things aren't working. The tricky thing is I can't just tell them, hey, look, you have synkinesis, your eye, your mouth, blah, blah, blah. No, I have to help them tell me what is wrong that's happening with their face, because once they feel it, then they can start figuring out how to suppress the unwanted movements. So what's really happening with this guy's smile? I take him through through guided questioning, asking him, where do you feel unwanted movement on the affected side? Now he's very aware of his eye, so he's like, my eye, it's closing. And I say, oh my goodness, is that what's happening on the normal side? No, it's not. Okay, well, what else do you feel? And we kind of move through the midface, what he's feeling in the midface. Oh, he's feeling pulling in his cheek. And then we start looking at the lower face. He's starting to realize he has tightness in his chin and in his neck. And then, and I even kind of draw this all out for the patient so that they're looking at the illustration. And then I ask them the million-dollar question. I say it nice and slowly. If you want the affected side to be more like the normal side, does the affected side need to do more, or does the affected side need to do less? And you wait for it. And then they have the realization of what's happening in their face. This is another lady. She was very disturbed by her lip pucker, and we can see the unwanted movements that are happening. So first, guiding her in the same way, we decide to target buccinator, because buccinator is actually pulling her mouth to the side. I have to kind of ask her guided questions, and she learns over time that she begins to notice that the inside mucosa of her cheek is actually pressing against her teeth, and that's happening on the affected side, but not the normal side. When she can tell me what she's really feeling, then she can start suppressing it. After she was able to suppress buccinator better, she realized there was a lot of pulling in her neck with platysma, and so we focused on that. And then when that was better, and you can see the shape of her mouth is better, she's realizing that her eye is closing, and that's really annoying. So she starts working on how to suppress her eye closure. She made a lot of progress. Is she going to be perfect? Is she going to be normal? She's not going to be normal. So at some point, she has to realize that the normal side actually probably also needs to do less, and that the puckering in this instance, she should only pucker as tightly as the right side is able, and not ask the affected side to do more than it's capable of doing well. I like working with physicians. I think physical therapists really enjoy that type of relationship with patients. It's great when we get the patient right away before they have Botox, because it's very difficult to help the patient understand what's inhibiting their improvement. And if they have Botox first, they have a harder time of knowing what's normal and what's not normal. So once they start getting it is a great time for me as a therapist to call the provider and say, they got it, let's go on with the functional Botox, which really helps improve their overall ability, and actually then allows us as physical therapists to kind of kick it up a notch and proceed even further with the neuro-re-ed. So thanks for having me here. It's a great honor. I'm so happy to see so many people I know and care about. And I think we had a great meeting, and I'm sure you're glad that I'm actually the last speaker, I think. Thank you.
Yeah, thank you, Laura and Lily. Great talk, great ending of a great day. What makes us successful as surgeons, and our encounter with our patients could vary from 2 to 15 minutes. 15 minutes is quite painfully long for us. But what makes us succeed in our work is the multidisciplinary approach we take on everything we do. We are as good as our audiology department is. We are as good as our vestibular rehab department is. We are as good as our facial reconstruction and rehabilitation department is. Because without all of these, assistance, we're just mere surgeons with poor results sometimes. So thank you for all what you do for us as a specialty. And your gift for the rest of the evening is you're going to be released from darkness now into the beautiful sunshine of Sarasota Bay. The shuttles, for those of you who are taking the Le Barge Sunset Cruise, I think they want us on the boat around 6:30. There are shuttles that are leaving this hotel starting, I believe, at 5:45, and they take 13 people at a time. So try to get there. It is walkable there, but you take your own life risks in crossing that roundabout. So I encourage you either to take the shuttle or to drive yourself there. It's just across here on the bay. It's called Le Barge, and we'll see you there. It promises to be a beautiful sunset cruise and an evening. If I'm not seeing you on the boat, I will see you tomorrow morning. So tomorrow it's a combined session again. So all the two rooms will be combined in one, and we will all be discussing the rest of the program together. Okay? Any questions, comments, words of encouragement?